Welcome to Multi-Care Ear, Nose and Throat Clinic. And today we're talking about functional endoscopic sinus surgery in a case of chronic allergic fungal rhinosinusitis in a 27-year-old female with nasal discharge, obstruction, swollen left eye, visual impairment, and she complains of yellowish purulent discharge. This is the swollen left eye you can see here. And this is a CT scan showing an isodense lesion in the left nasal cavity, anterior posterior ethmoid, and then into the sphenoid, and then eroding the skull base posteriorly. The same isodense lesion obstructing the osteomeatal complex and into the region of the anterior ethmoid. And we can see the lesion in the sphenoid, the left sphenoid, with erosion of the posterior ethmoid on that side. Now on the right side we can see the same lesion in the right ethmoid, posterior ethmoid, and then the sphenoid. Now in the theater, the patient is under general anesthesia with a packed endotracheal tube and the pharynx was packed. And we can straight away see some purulent discharge, yellowish, thick, the characteristic chocolate-laden crystals. And you can see it's so difficult to suck out with a suction nozzle, and we have to irrigate with saline and then get some of those sticky secretions out. And straight away we can see the nasal cavity, and we can see some polypoidal lesions in the left nasal cavity. That is the inferior turbinate laterally and the septum medially. And we can see these polyps in the medial meatus. Now we use a straight debrider blade to debride some of the polypoidal lesions. They are relatively bloodless due to adequate nasal preparation and preoperative steroid preparations. Now we can start seeing the middle meatus. We can see the polypoidal and grossly diseased middle turbinate begin to show up in the center of the view. You can see how polypoidal the middle turbinate is. Some fungal lesions between the middle turbinate and the septum in the area of the olfactory cleft. Some fungal concretions. And on opening up the anterior face of the bulla ethmoidale, we can begin to see the whole content is filled up with fungal concretions. Now you can see the fungal concretion in the bulla, the ethmoid cells. More of the fungal concretion. And it's always a good thing to open the bulla at this stage so as to clear enough of the fungal concretion so as to give you a clearer view, a much wider view into the medial meatus, so you can identify the structures more clearly. debridement still taking place. Now we can begin to see the view into the choana, and that is the final common pathway in the region of the posterior frontal. More polyps and fungal material has been debrided. Now we can see the everted onsnate process, and that is the face of the bulla, which we partially debrided, and on gentle pressure you can see fungal material has been squeezed out of the ethmoid eye cells. That is the hiatus seminaris inferioris, and we can see the region of the infundibulum being filled by fungus. So we decided to start the procedure by doing a middle metal antrostomy via the retrograde approach to identify the antrum, the region of the orbit, now we're taking a bite into the next point, and clearly we can see the infundibulum. So we fracture the horizontal portion of the onsnate process by pushing it downward with controlled pressure. Already there are 40 micro debrider blade to debride the polypoidal lesions, the horizontal portion of the onsnate process, and we gently find our way into the maxillary sinus os. And that is the maxillary sinus os. You could see the air bubbles, which confirms our position. So much edematous inflamed mucosa, and we can begin to see into the left maxillary antrum filled with fungal and polypoidal lesions. More fungal concretions been debrided. Now use a 90 degrees plexus forceps to excise away the lower portion of the face of the bulla ethmoidale. You can see due to chronic inflammation, it's a little bit fibrous and tough. And that's the lower portion being excised out. And that gives us more view into the area of the infundibulum, and by extension the left maxillary sinus os. I'll suction away some of the blood, and you can see the left maxillary sinus os now becoming clearer. And then we can begin to see the ground lamella grossly edematous, and that is the maxillary sinus os, the ground lamella, and this is the everted portion of the vertical process of the onsnate process, being everted in order to make it easier to avulse or excise. Now use the same 90 degrees plexus forceps to tease out the vertical portion of the onsnate process. And at this junction we need to be a bit careful, because we know that the laminar papyracea has been eroded in some portion, so let's try to stay vertical and parallel. Now you can see the defect in the laminar papyracea has been proven by a positive Stankovic sign. So we need to be very careful in order not to go into the orbit through that defect. So it's always a good thing to use a 3.5 millimeters Rad 40 blade rather than the very aggressive 4 millimeter blade, so as to prevent inadvertent injury through the defect to the orbit. So more debridement taking place, and we're defining the region of the laminar papyracea. And we're coming towards the area of the frontal recess, and you can see the disease and grossly edematous agar nasal cell. Now try to define the margins of the edematous agar nasal cell, debriding the face of that cell, its posterior wall, and that will naturally lead us into the frontal sinus. Now we hug on the beak while debriding this. Now we'll go to the area of the laminar papyracea. And you can see the defect in the laminar papyracea and its positive Stankovic sign. So that's the defect there. So you try to avoid that area. Take note of it. Always be conscious of that in order not to cause injury to the orbit. So continue the operation by using a spoon curette in order to scoop out the diseased agar nasal cell forwards and upwards. Lots of diseased mucosa. You can see the air bubble sign showing us that we're in the area of the frontal recess and towards the frontal sinus. Now there are two openings here, one laterally, one medially, but usually the medial one close to the middle turbinate will naturally lead you into the frontal sinus, while the lateral one is most likely going to lead you into the laminar papyracea and the orbit. So be very careful here. Try to define each cell as it evolves and debride them gently. Now stay close to the middle turbinate and close to the beak, frontal beak. So read a Rad 60 micro debrider blade to debride more cells around the region of the frontal recess. Lots of edema, and we can see some fungal concretion and some polypoidal material. So gradually we keep debriding the edematous tissues. You can see the attachment of the middle turbinate quite unstable with lots of polypoidal lesions. So we define the middle turbinate, and now you can see the opening into the frontal sinus right there. And we can see some fungal concretions being gently sucked out from the left frontal sinus. You can see some cheesy material, more of Charcot-Leysin's bristles. And that is the anterior table, the beak of the frontal sinus. Always a good thing to go in, irrigate thoroughly in order to ensure that there are no fungal concretions left out in the frontal sinus. Now we irrigate several times, and right away you can see lots of fungal concretion being flushed out of the left frontal sinus. Now you can see the quantity of fungus coming out just from the left frontal sinus. Lots of fungal material. Now irrigate it several times until it becomes very clear. Now straight up using a 70 degrees endoscope, you can see the anterior and the posterior table of the frontal sinus with the scalloped margins. And that is the attachment of the bulla ethmoidale to the anterior skull base. So use a 45 degrees black sleeve forceps, or alternatively you can use a giraffe, and tease that down gently as we're beginning to approach towards the area of the cribriform. So gently tease out the superior attachment of the face of the bulla on the anterior fovea. Always do this under vision so as not to cause injury to the skull base. Now we're using a 60 micro debrider blade to further debride those cells, and the bony septations are teased out. Clearer view into the anterior fovea region. Now towards the midline you can see the middle turbinate, the laminar papyracea showing more clearly, and posteriorly is the skull base. And we're scooping out and suctioning out more of the trapped fungal concretions in the region of the anterior fovea. Attachment to the laminar papyracea have been teased out. Now it's always a good thing to use a radinoid blade to debride away polypoidal lesions on the posterior surface of the frontal sinus. And we can see the posterior table being flushed towards the anterior fovea, and laterally is the laminar papyracea, and medially is the middle turbinate, and anteriorly is the frontal beak. So tease away polypoidal mucosa, being very careful not to strip away mucosa. You can see how deep the anterior fovea can be in some patients, especially in this patient where there has been a lot of fungal infection with the pressure, expansion, and erosions. Now debride away more of the anterior ethmoidal cells, and we're gently coming towards the region of the anterior ethmoidal artery. So need to be more careful. Always debride under vision to avoid inadvertent injury to the anterior ethmoidal artery. Now we can see the fungal concretions expanding the cells there. So suction out more of the fungal concretions in the region of the fovea. And we can now see a clearer view into the frontal sinus, the anterior fovea, and we're heading towards the region of the posterior ethmoidal air cells. More of the fungal concretion and edematous mucosa extending into the region of the laminar papyracea. So clean up the lesions there so as to define clearly the position of the laminar papyracea, which should always be in your view. And remember the area where the defect is and try not to go through it. So gradually and gently you can see the anterior fovea being cleaned. And above there is the region of the anterior ethmoidal artery in the center of the operative view now. Debriding more of the diseased ethmoidal cell and their attachment to the laminar papyracea laterally. Now we're down with a 0 degrees endoscope. And you can see we're defining the ground lamella using a true cut straight nasal forceps to break down some of the septations and further expand the maxillary sinus os. Now in the center of the view we can see the ground lamella and its superior attachment, and that's a fungal concretion in the region of the posterior ethmoidal cell superiorly. Now you can see how diseased the middle turbinate is, looking very unhealthy, and we'll take a decision on what to do with the middle turbinate, but it's grossly diseased and very unstable. Now if we go through the ground lamella, it will lead us towards the lower portions of the posterior ethmoidal cell, further defining the middle turbinate. You can see it's so grossly diseased, lots of hypertrophic mucosa, a bit fibrous, and all this is disease, and we have to excise them in order to give a clear drainage and aeration to the paranasal sinus. Debriding more of the ground lamella and in the inferior-medial and inferior-lateral portion of the bulla ethmoidale. Those are the remnants of the bulla ethmoidale anteriorly, and we can see the entrapment of the fungal concretions in the lower portions of the bulla ethmoidale. Now define its attachment to the laminar papyracea, and that is the attachment of the ground lamella to the laminar papyracea, which we're breaking down and excising gradually, as that leads us straight into the posterior ethmoidal cells. You can see how unstable the middle turbinate appears to be, and at this juncture we made up our mind to do a partial middle turbinectomy in order to give us clearer view into the operative field and grant us access into some trapped fungal concretions. Now during this turbinectomy, be careful not to slice through the skull base in order not to cause injury and CSF rhinorrhea. Be very careful. Always see what you're cutting and what you're debriding. We can see the skull base now, and then the anterior face of the sphenoid sinus. We'll tease that away. and right away you can see a clearer view towards the area of the sphenoid recess, the face of the sphenoid, the posterior ethmoidal saw, more access towards the laminar paprasia, more exposure to the maxillary sinus os. So debriding away the diseased mucosa. Now we're taking out the diseased passans ridge, which has been grossly eroded, and staying flush to the septum will lead us into the sphenoid sinus os. And as we can see, the sphenoid sinus is grossly filled and packed with fungal concretion. Now, having exposed the anterior face of the sphenoid, the attachment of the middle turbinate, we decide to debride away the passans ridge in order to expand the sphenoidotomy and then merge it with the posterior ethmoidal saw, so as to give us a wider opening into the sphenoid sinus. Now debride towards the floor, and we're being careful not to run into the sphenopalatine artery that can cause torrential bleeding. Now we're in the sphenoid sinus, and you can see lots of fungal concretions being trapped. That's fungus. Lots of fungus. So keep irrigating. That's the area of the optic nerve there running, and you can see the optic nerve is exposed, and that further highlights the need not to use powered instruments or forceps in the sphenoid cavity. You can see we're flushing out lots of fungal concretion from the left sphenoid sinus. More fungal concretion. More fungus being sucked out. More fungal concretions, and we still have to open up the face of the sphenoid so as to allow post-operative steroid irrigation to be very effective. More fungus being sucked down. Now beginning to have clearer view into the sphenoid sinus. You can see the hypertrophic mucosa, which is better left alone than pulling on it, because the carotid artery can become eroded, and some of these attachments can be towards the adventitia of the internal carotid artery. More fungal concretions. More fungus being sucked out. Now you can see more fungus towards the area of the clivus. Now you can see where this lady was having proptosis of the left eye with some visual impairment in the left eye. because the optic nerve is already dehiscent, has been eroded, and there is pressure and inflammation from the fungal material. Her vision improved remarkably, almost back to normal post-operatively. Now that is the region of the optic nerve laterally there. The region of the clivus. You can see a dilated and expanded sphenoid sinus. You can see more fungus being trapped in the clefts. Now decided to widen the sphenoidotomy, like I said earlier, in order to allow for post-operative steroid and saline dutching and for post-operative diagnostic examination, endoscopic examination. Now we're flushing the face of the sphenoid with a laminar papyracea in order to give us maximum exposure. Now you can see fungus being trapped in the area of the optic nerve. Now you can see the dehiscent optic nerve running there. That's the optic nerve exposed, and below it is a carotid artery which still has some bony covering, thankfully. That's the optic nerve. More fungal concretion being suctioned out of that sphenoid sinus. You can see the quantity of fungal concretion still coming out from that left sphenoid sinus. Now that is the maxillary sinus there. Now decided to suction and inspect the left maxillary sinus. After several flushes, suctioning, you can see some cheesy material in the left maxillary sinus. And with suction you can see how clean it is, and that is the area of the last molar tooth, the root of the last molar tooth. Now we go to the right side of the nasal cavity. Remember, the anterior ethmoids were spared, but the posterior ethmoids had fungus or diseased, and the sphenoid is also diseased, and then the osteomeatal complex on this side was also obstructed. So we begin the procedure by doing a medial meatal antrostomy using our usual technique of the retrograde technique, using a backbiter, which appears to be one of the safest procedures. Hardly do people use a sickle knife these days to do an onsenectomy. Now using a rat 40 blade to divide the area of the next point, the area of the right infundibulum, and naturally that leads us into the left maxillary sinus. And you can see the sinus here, it's relatively clean, just obstruction to the osteomeatal complex. So decided to do a normal antrostomy on this side to allow for ventilation and drainage of this maxillary sinus, remnants of the horizontal portion of the uncinate process being teased out. Now use the ball probe to invert the vertical portion of the uncinate process, just like illustrated on the left side. We use a 90 degrees Blexley's forceps to tease that out. Very straightforward and easy. Now we'll go towards the area of the frontal recess, and we scoop out the anterior ethmoidal cell. The anterior wall, the posterior wall of that cell, gliding on the face of the bulla, should naturally lead us into the area of the frontal recess and the frontal sinus. We use a RAT 60 micro debrider blade to debride away the remnants of the anterior agar nasal cell. And gliding on the face of the sphenoid should laterally lead us into the frontal sinus. And as we are aware, the frontal sinus on this side is normal, not diseased. The anterior ethmoidal cells are normal, just the posterior ethmoidal cells and the sphenoid are diseased. In this, you can see the frontal sinus there, clean, normal mucosa. Now decide to do a bullectomy here and remove the remnants of the bulla ethmoidale, its attachment to the skull base and to the orbit. Now, having excised away the anterior ethmoidal cell would naturally lead us to the grand lamella. And these are some remnants of the anterior ethmoidal cells and their attachments to the fovea ethmoidalis. Now the attachment to the fovea there. And that leaves us with the grand lamella. You can see the anterior ethmoidal artery running in the center of the view there. That's the anterior ethmoidal artery there. Now we're debriding away the ground lamella, and naturally that should lead us into the posterior ethmoids. You can see the diseased posterior ethmoid. The mucosa is hypertrophic here, thickened. You can see the mucosa here, some fungus in the posterior ethmoids on this side. That's fungus there. And you can see the hypertrophic mucosa. You can see the mucosa there. Hypertrophic mucosa. And you can see more of the hypertrophic mucosa there being debrided. A piece of the ground lamella being excised, and you can see the hypertrophic mucosa. That's it there. So debride some part of it and lay the normal portion of it. And that is a huge posterior ethmoidal cell that was being highlighted in red in the CT scan earlier in the case. can see more of the hypertrophic mucosa being teased out. That is a hypertrophic mucosa in the posterior ethmoid. And that gives us a clear view into the posterior ethmoidal cavity with the erosion of the face of the sphenoid that leads into the sphenoid sinus. And we can see the clivus. You can see some fungal concretion. And that's the carotid artery just in front of the suction there. The vertical portion of the paraclival carotid artery. The lateral recess area of the sphenoid. Hypertrophic mucosa. The area of the lateral optical carotid recess. The clivus. And we can right away see some fungal concretions too being suctioned out. The lateral recess, the clivus. We can see the sella tossica just above the suction. The area of the tuberculum sella and the area of the plenum sphenoidale. These are some of the intrasphenoid anatomy which we can see. So we thoroughly irrigated the nasal cavity, the sinuses with concentrated methylprednisolone solution. After several thorough irrigation, you can see the huge left medial meatal antrostomy, the frontal sinus, the frontal recess, the anterior ethmoidal artery in the center of the view there on the left side, the area of the posterior fovea. You can see the eroded portion of the posterior fovea there. You can see the erosion around the 1 o'clock position. The choana have been suctioned out. The remnants of the medial turbinate, the frontal sinus, the laminar papyracea laterally, the eroded portion of the posterior ethmoidal fovea, and you can see a clear view into the post-operative cavity, maxillary sinus os, the choana, the white sphenodotomy, the eroded portion of the posterior ethmoid fovea, the anterior fovea, the frontal sinus, and this is the right side, the inferior turbinate, the septum on the right, the right huge posterior ethmoidal cell, and we can see the maxillary sinus os, the posterior ethmoidal cell, and that's the anterior ethmoidal artery. We can see the intrasphenoid anatomy, the clivus, the paraclival carotid, the lateral optical carotid recess, the sella, and that is the post-operative cavity as earlier illustrated on the left side. The sphenoid and the intrasphenoid anatomy earlier illustrated. Thank you for your time and thank you for listening.